Welcome to the Owens Recovery Science Podcast, where we dive deep into all things blood flow restriction training. I'm your show host, Johnny Owens, and whether you're a clinician, researcher, or athlete, you've come to the right place. Each episode, we break down the latest research, interview leading experts, and translate complex science into practical applications. We're here to bridge the gap between laboratory findings and real-world implementation. All right, welcome to another Owens Recovery Science Podcast. I'm your host, Johnny Owens, and I'm here with Kyle Kimbrell. We're going to have a guest on that I'm very excited about today. But first, I got to get my ragging on Kyle out of the way. Yeah. Kyle, you look balder than normal today.
I do?
Yeah.
I actually need to shave. There's like...
Really? Maybe that's what it is.
I don't know if you can see, but there's little tiny hairs.
I think it's just like the light's reflecting off the right side of your face more, so it looks more bald.
I got, you know what, I got this new cream for my head, and it's called
Please just stop. I just had lunch. Gross.
Mattifying cream. So I exfoliate, and then I shave, and then I mattify.
Oh, you're a manscaper now.
Yeah.
Yeah. Dude, don't even worry about it. There's no help. Like I was going to mention, get one of these like the podcast light things, but don't waste your money.
No, yours is
nothing's
shiny.
going to help. Nothing's going to help.
Your forehead's getting kind of deep, actually. It might be, I don't know.
I'm 55, bro.
Is it
like
going
I have any hair?
This way? Looks like it's kind of going that way.
I don't have a forehead. I have a five head.
A five head, yeah. Hey, five head.
All right. So anyways, I don't want to make our guests around too long, but it's been a minute. We got a ton of podcasts planned out, some really amazing guests and topics coming up. So I'm excited. We've been super busy. Kyle and I were out at the NFL meetings in Arizona not too long ago, which was awesome, getting to see all of our friends there. Speaking of Mark, if you have any insight about what happened with the Patriots coach out there, because that was right by our hotel. If you want to dig into that,
no comment for you on that.
No comment.
All that drama was dropping while we were there.
While we were there, man. Yeah. I know. I wish I would have got one of the photos at the hotel.
Dude.
Got it onto TMZ or something, but yeah. And then we just had the SHOP conference, the NASA conference last week, which I missed because I'm in a freaking move, which is the most painful thing in my life. I'm moving to Arizona. They say there's three things, I think. I don't know if this is really three things, but death,
taxes,
divorce, and moving are like three of the most painful, stressful life events. And I think it should be moving right before divorce, because the move is about to cause a divorce with me and my wife right now. I think because guys and girls are so different, bro. Like my wife, everything is going, and for a guy or me, I'm just like, dude, I don't need it. Like I've got plenty I got baby pictures on my phone. Let's just throw them all out type of thing. And she's keeping all the plastic containers. So anyways, it's been painful.
You gotta be team throw everything away. Moving is a great opportunity to just purge.
Clean,
all
right?
Items.
Clean.
Absolutely.
I mean, do we need to take plastic to-go containers from like Chinese restaurants?
No.
That's a little too small.
We got a box for it. We got a box for it.
No.
And speaking of conferences, Kyle. A little birdie across the hall in the office told me our brand new conference. So, Mark, we are rebranding and we got a whole new conference kit and background. We finished, and Kyle needed to send it back to our main offices here in Texas. He ships it with the label from the company that built it for us. So they shipped it back out to the company that built it for us rather than come to us. So public service announcement. If you're going to ship something, pull off the old label first.
Redo the box.
That's the problem. Those things don't come off. They tear up the box. So what they're supposed to do,
just ship it to the other people and hope they ship it back to us?
No, what the UPS people are supposed to do is they take a blank sticker and they put it over it. That's what they've always done every other time I've done this. But
Kyle
how
has UPS
I
problems.
love UPS. Dude, Brown don't do for me ever. Let me tell you.
Kyle has some real UPS problems.
There's a FedEx ad right now.
I went to FedEx. I literally went from FedEx to UPS. Great experience at FedEx, UPS.
All right. Well,
Anyway.
enough about shipping. Let's get to our guests
Yes,
and Kyle's
annoying.
problems. So today I'm excited. We have Mark Murphy, who is up in Boston at a fairly new facility. We call it C-Spar. Let me get the exact name: the Center for Sports Performance and Research. So it's part of Mass General. If you guys don't know, Mass General is, I think it's the biggest healthcare system up there. It's kind of associated as being with Harvard. So I would just call it Harvard General. That's just, the branding sounds much better than Mass. You might want to talk to your leadership on that for me. But Mark is the Applied Sports Science and Performance Lead at the Center for Sports Performance and Research, which we're going to call C-Spar from the rest of this point out.
Center for Sports Performance and Rehab?
Research.
And research. Okay.
And it's primarily all research right now, which Mark will get into. But I was introduced to him by our good mutual buddy, David Clancy, who's over in Europe, who had nothing but great things to say about Mark. And after we talked, I was like, man, I want to get you on the podcast so we can go through everything you guys are going to do at C-Spar, currently doing, future doings, and also you have a paper out, kind of a review paper on your thoughts of BFR and bridging the athlete. So he's got some really cool return to play stuff I think we talk about. And lastly, lucky bastard, he just got to go to Isokinetic in Greece and presented blood flow restriction stuff over there to the Euros. I did Isokinetic in France in 2019. It's a cool conference, man. A lot of fun. The shirt would have looked great there. My tight Euro Italian
Formula One,
my Formula One
BFR
Italian shirt. So with further ado, Mark, welcome to the podcast, brother.
Yeah, thanks for having me, guys. Really appreciate it. Look forward to chatting and riffing on some good BFR content today.
Yeah, man. Yeah. So give us your background. Like, where are you from? Where'd you go to school? And how'd you end up at C-Spar?
Yeah, so I went to the University of Rhode Island for undergrad in 2011 to 2015. I played college football there. And so throughout my experience playing college football, I really loved the weight room training, trying to become a better athlete. Had some injuries to that time, and then always wanted to be a strength conditioning coach. And then got hurt, was like, you know what? Went to physical therapy, rehab an ACL, and realized there's a huge disconnect between strength training and rehabilitation. I was like, what's going on right now? Like essentially my, ADL is going to have to be like running into someone, right? And we're not progressing past heavier loading when we should be, right? And I thought, well, I'll go to physical therapy school and get good at bridging the gap between this component. Like, here's the problem, let's try to solve it. So went to physical therapy school at the University of Rhode Island from 2016 to 2019. Throughout PT school, I was a strength conditioning coach with the football program and the other teams on campus. And then upon graduating, I came on as the rehab and return to play coordinator for all of our student athletes. So it just worked out like, hey, you've been the strength coach here for 3 years. You're now the physical therapist and then handling out kind of the rehab and return to play protocols, and was there from 2019 to spring of 2023, and then got recruited away from University of Rhode Island to Mass General Brigham to serve in the role I'm in right now in our Applied Sports Science and Performance Lead in C-Spar. So it's been fun.
And you're still teach at Rhode Island.
Yeah,
as
so
well as a couple
I've been teaching at the University of Rhode Island since 2019, since a few months after graduating. So I'm teaching our sports physical therapy courses, did some guest lectures in BFR, Applied Anatomy, our MSK courses. And then I teach as well at Bridgewater State University in the teach course on exercise metabolism at both the graduate and undergraduate level. And then I'm adjunct and clinical faculty at the MGH IHP Ortho and Sport Residency program. So education is a big part because, we can know a lot, right? And we can have good experiences clinically, right? But if we can meet students at the entry point, right, when they're in school and give them exposure to these very high fidelity technologies or cutting edge interventions, right, when they're building their principles, right, they're going to be that much more successful when they graduate and elevate their own practice, Yeah.
Yeah. And well, I don't know about Rhode Island. I taught BFR up there a long time ago. It was our mutual friend, Justin LaFerrier, who's about to be on our podcast, who brought me up there. But my PT school certainly didn't teach me bridging the gap from rehab to performance with athletes. That's for sure. So we need so much more of that, man. The lack of exercise and physiology knowledge we have in PT schools drives me nuts. So
yeah, that was kind of like the impetus to go to PT school, so to speak, and to teach upon graduating. Because throughout PT school, I'm sitting in MSK1 and MSK2, and they integrate some TheraX in there. And so often my classmates are coming to me like, hey, how would you train this? And meanwhile, at 5:30 in the morning to 7:50 when lift finishes and run over for the 8 a.m. class, I was training Devo lift in football, for our whole periodization of our off season. So it's like, well, yeah, this is just like we're just training in the presence of injury. Like this is the same thing. This person just has like an acute disc herniation. We're just gonna significantly lower the load, regress the pattern as much as possible to find the right entry point to loading. And then BFR came along. I've been familiar with it for many years, but I was like, okay, now I'm a clinician, I can actually utilize this, and then you can certainly see a lot of things elevate. Because the way I looked at it was like athletes, when they get hurt, right, they should never leave the weight room. They should never be taken away. Like the leave the weight room, go to a clinic for 6 months, and then pop out later. Like that's a disaster. You're going to have a negative outcome. They should never leave the weight room throughout their entire rehabilitation process. And so BFR gives us a valuable resource to continue having entry points to loading from a strength conditioning standpoint, right? Also from a rehab standpoint, so we can all make better use of our time, right? Because like I've talked to a number of groups about this, like pro sport organizations can buy whatever they want, right? And in me working in college sports, at Rhode Island, we're a mid-major institution, right? So started to realize the value of time, right? So time is your most valuable resource in all levels of sports medicine, from youth sports to pro sports to your master's athlete to any person on this planet, right? Because you cannot buy more of it, right? You can buy more equipment, you can buy better players, right? You cannot buy more time. The game's on Saturday, the next game's on Saturday, right? And so I realized, hey, if I'm going to maximize the talent we have available to us at Rhode Island to help improve our programs, I need to make better use of the time we have with our athletes across the week, right? BFR can be this incredible tool to make better use of your time, right? And so when you're in season, right, we have to make sure we're making the most out of every training day in between match day to maximize preparation and potentiation of the athlete, right? And as well, when the load compromised individuals coming off of a surgical case, right? They only have so much time. I know what in rehab, it's like, oh no, don't be time based in your rehab, be objective criterion based. Absolutely. But we only have so much time to hit the objective criteria we need prior to when we need someone to be ready. Obviously we can push timelines a little more and when there's less at stake, right? But the higher we go in sport, it determines our risk tolerance, right? And so when we think about BFR as an intervention for any of these components, I think, physiological cross-sectional area is like the foundational performance precursor to the expression of strength and power. Like that is a fundamental principle, a hill I will die on, right? And there's no better tool than BFR to express muscle hypertrophy or improve muscle hypertrophy in a load compromised state. Right. So if I can expedite the return of skeletal hypertrophy or mitigate disuse atrophy, right, I'm going to set myself up when I have a joint that has has better structural tolerance, right, or skeletal integrity, whatever it may be, a cartilage procedure, the ligamentization process has progressed, right? Now I've restored enough physiological cross-section where I can get more out of the joint when I'm trying to elicit some strength and power adaptations, right? And then on the flip side to all that, BFR is also a phenomenal tool for either in the use of aerobic exercise, right? Because like aerobic fitness is the foundational, is the foundational performance precursor to the repeated expression of strength and power. So yes, you need the skeletal hypertrophy to do the job. You need enough sarcomeres in series. Wonderful. Can those sarcomeres in series go more than 3 plays in a row? I would hope so. Otherwise, we're going to be fairly ineffective. You know what I'm saying? And so, when a lot of times we miss on early aerobic exercise in our post-operative cases, right? And fatigue will then set in when we're trying to do drills that express strength and power, where we actually don't get high threshold motor unit recruitment because we're too fatigued to actually do the drill, or the athlete's too fatigued, right? So utilizing BFR early on after surgery, you can get a ton of supplemental zone 2 work in, and not only from the central cardiovascular adaptations peripherally, that's going to help mitigate, fat infiltration to the muscle belly, right? You're going to stimulate some mitochondrial density, right? A lot of positive effects are going to happen. So, but in the absence of not using BFR, you're really kind of handcuffing yourself early on when you could be making better use of your time. So that's a little spark notes on my thoughts on that.
Yeah, I think you had a good line. It was, like muscle, the hypertrophy and strength that we can get is one of the most modifiable things we can do in rehab. That's so true. It's an organ that changes quickly in a bad way or slower in another way, but we have to look at it almost like clay, that we have to figure out a way to modify, to understand the right physiology to give it a stimulus to do that. And it could be slowing catabolism all the way up to anabolism and trying to get that strength and hypertrophy. And so many of us are just like, 3 sets of 10 versus like, what can we really do to modify it? So I dug that quote.
Run with it.
I might steal that. Take us through when
Yes.
so you took one of our courses, I think. Like you said, you knew BFR for a while, but when did you start, and when did you first start kind of applying it? Was it just in clinical scenarios? Was it at Rhode Island as
I
a
was
strength
using it,
guy, or how'd it go?
like training myself as like in like end stage high school, and into college. And so my dad
Yeah,
was
tell the
a
story of your
competitive
dad. I forgot about
bodybuilder
that.
in
Yeah.
the 80s. And I remember reading about like BFR interventions in high school because I just liked exercise physiology. In high school, I was like, oh man, I like to lift weights and sprint, and I wanted to dunk a basketball. So I was like, oh, how do I jump higher? I started reading like jumping into plyometrics and all this sort of stuff. To like, I did have a pair
Did
of
you wear the
jump shoes.
jump
My
shoes?
buddy down the street, T. Welsh, had a pair, and
Me
he could
too,
dunk
baby.
from the foul line. And he was like, dude, you need to jump. And
Nice.
when you're 16, you're like, absolutely, that
All I could do was the Nerf hoop in my room. That was as high as I could get.
but those are great. Yeah.
Oh, they hurt, man. That's why I walk on my toes.
It
I
just
think I
puts
wore
you
them so much. My calves.
in like a shortened position of your gastroc, and it's like, don't lengthen. Yeah.
I'm like a little CP kid walking around.
Yeah. Those are
I
the
remember just doing
craziest looking shoes.
plyometrics on like a picnic table at the local basketball court with those on with my buddies. Just as a kid, you're like anything to get an edge, right? But yeah, so my dad would tell me, he's like, oh yeah. I was like, Dad, you ever heard of this stuff? And he's like, yeah. And like backstage before a show, guys would, put a tourniquet around their arms or just like rubber bands and do curls and get a pump. Lifting straps, right?
Yeah,
And
lifting
so
straps,
I was like,
right?
oh, okay, get a pump. And so I was like, 17, 18. I was like, oh, I'll get a pump too. And would do it to get a pump. And I was like, hey, this feels pretty good. And sometimes I do it like with like leg extensions and things like that, like isolation based stuff, but just as like a naive high school kid to get a pump. And then when I got into cell swelling, right?
Cell swelling, baby.
And it would feel good,
anabolic,
right? And then when I got
too.
into college and was playing college football and training for those components, during winter breaks, I'd be, working out in the basement and things like that before, formal team activities. And I always would kind of cycle back to doing some things like that you do as, a kid when you're training and things like that. And then was familiarized myself more with it, talking with our professors at the University of Rhode Island through undergrad and talking with them and cool things like that. And then through PT school, used it a lot with some of our athletes at Rhode Island with some interventions with either just a regular strap to getting some occlusion components. We had smart cuffs and things like that. And then throughout my clinical rotations, I got exposure to smart cuffs, B-strongs, and all that. And then right when I finished, and then also Delphi units through my clinicals. And then in May of 2019, when I graduated PT school, it was like May, June, that last weekend, I took the course with you guys. I guys had one in Dedham, Mass. And I was like, well, there's no, I was like, I'm not going back to any other unit. And thankfully, by taking that course and being a faculty member around, we were able to buy some units that we were able to use with our athletics and sports medicine departments, which we then have been using ever since down there at URI.
Nice. Same thing at C-Spar. I mean, we do a ton with Mass General already in their clinical side, but same thing as C-Spar. You guys are all using Delphi, it sounds like. Yeah, so cool. You can really prescribe it outright. That's good. So let's go into, because I'm going to be interested to really see how you're applying this in the later phases. But we all know kind of how we do BFR in the early stages, but take us through how you're doing it, maybe with some different cases and maybe different ways. Maybe
so the primary way I've used it in end stage rehabs historically in the past is using it in a high mod low model. So like you have your high intensity stimulus stay, your moderate intensity stimulus stay, and your low intensity stimulus stay. And a lot of times that what stimulus I'm picking or we're picking as a strength staff and athletic training staff and rehab department is heavily based off of what's going on at practice, right? Because now this athlete they're practicing. They might not be a full participant at practice, but they are doing a lot more high volume or running, cutting activities, right? So I know they're eliciting some high threshold motor units in those tasks, right? And when you think about the rehabbing joint, there's only so much tread on the tire, right? And so when they have that exposure to the high threshold activity, which is good, you want that to happen, but you almost have to retread that tire prior to the next bout. Eventually you get to the point where you have a nice, fantastic tire who can go all day. But in the high mod, low model, what I found success with is saying, okay, hey, if I know the intensities they're going to hit on the field are like, let's say it's a full padded practice, or let's say from a amount of reps or yardage that individual is going to run, right? If I know it's high at practice and what we need to do with that individual when we have access to them in the weight room for their weight training session is a low intensity stimulus day, right? And BFR is going to do the best use of that to elicit, and maybe it's as low as BFRT with aerobic exercise for 20 minutes. Maybe it's as low as a passive self-swelling protocol, right? Or maybe it is, hey, just 2 to 3 sets or 2 to 3 exercises of a 30-15-15-15 protocol of the same movement pattern the strength coach wanted to train that day, right? But we're just regressing the load, because the way I look at it, there's 2 pathways to eliciting muscle growth, right? We can either go mechanical tension, super heavy weights, right? 3x5, 5-3-1, let's go get it. I'm all for that. I like that. However, if the joint can't tolerate it, we can certainly go take the off ramp at metabolic stress, and we can cook them. Right now, it's not pleasant. Your athlete's going to be like, "Oh my God, this is brutal. I got the cuff again today." It's like, well, you did so well at practice. You did so well at practice today, buddy, that you get to get the tourniquet. Yeah.
This is your reward, baby.
And you can put it in a number of different ways. Like, as long as you're dosing it correctly, like from an aerobic exercise standpoint, like let's say you utilize that as your intervention with them, right? And you can use heart rate max as an easy intervention with them, or heart rate reserve, right? So you just say their max heart rate. If you don't, just take 220 minus their age, right? And then take that heart rate max minus their resting heart rate, and then times that by either 0.5 or 0.6, right? And then you just do an activity that keeps them in that target heart rate zone, and do it repeatedly. Okay, and it's super easy. Set it and forget it. Could be put them on a bike. Kids like iPads. Here you go. See the little polar heart rate strap? Keep it in the green, and the kid's like, oh, they think it's a game, right? And they're blown away. And you just are continually finding ways to elicit the adaptations. You can go continuous, or 3 to 5 minutes on, 3 to 5 minutes off. Find the right entry point to the individual, right? And
do you have a favorite? Like, I prefer the bike, but it seems much harder than treadmill, and so I get some people that really prefer treadmill, but then I just feel like I can get to that stimulus and maintain
I prefer the bike because it's like they're stationary, they're seated, like any intervention of BFR exercise, like start sagittal, start in a position that minimizes their ability to maximizes or minimizes their challenge to manage gravity. So like seated. That's why like machines are great for exercise. I find the bike is helpful. I find a sled is a fantastic tool as well, as long as you're setting the distance over time. You don't need to put much load on it. I think where we go wrong is we go, oh, it's a sled. Let's put heavy weights on the sled, because the nice part about a sled, it's primarily a concentric activity. Right. So the goal with any aerobic stimulus you're providing through BFR is try to pick an exercise modality that's concentric biased. Right. That's why cycling's great. That's why incline walking is a nice tool as well. All those sort of things. Right.
A lot of the big stuff with NASA that we're looking at right now is with rowing as well. Pretty tough. Yeah. Just lower extremity.
That, Johnny, I think you and I talked about it. It's an old school resistance exercise.
It's a flywheel.
No, it's the thing with the rope where it's just like you dial the tension and you just pull in the rope. I can't remember the name of it, but
the one they were actually doing on the space.
Oh no, not on the space station. Yeah, on the space station they were doing the flywheel. I was just talking about, we had, instead of like a concentric type thing.
Yeah.
Instead of like a sled, there's like a little cylinder, and you can dial up resistance in it, and there's a rope that threads through it, and you pull the rope. And so
I remember that. You put it in a door or something?
Yeah, you put it in a door, tied off to a pole. I got like a harness
like
that I could use. I know, yeah. It is, but it was great at the clinic because I could tie it off to something super easy
Yeah.
and anchor it, and they could do like a sled pull in reverse or forward,
Yeah. It's
and
interesting.
it's just a little bit of resistance to it. It was
Cool.
awesome.
I'm just so happy I'm hearing
Can't remember
Mark.
the name of it.
With a million things you're doing, you are working in so much aerobic as well.
It's like, because
such a
you got to
missing
make the most
piece.
of the time, right? So
All
like
right,
if
man.
I have an off day and we're
Yeah.
early post-op and they're like, what should I be doing today? I'm like, this is something. And you facilitate a culture where something is happening every day on their calendar, right? In the team sports setting, that's super easy to do because you have access to them, right? If they don't come, there's repercussions.
Mhm.
In the outpatient clinical environment, you can educate, right? Hey, I want you to start doing this on your own when you're not with me. But as soon as you can foster that behavior with an individual of like, hey, this, if you want to have success in your rehab, it's going to be a result of simple daily positive actions compounded over time. And so if you can be doing something every single day, we're going to have success. So it's kind of a different use case in both settings.
Very cool. Let's just go through some of your typical rehab cases then. So I know you guys have a lot of cartilage work with
Dr. Christian
your
Latimer.
surgeon there. What's his name? He's the president of this. Yeah, big dog, president of the Cartilage Society. So let's say you get a big old cartilage procedure, 8 weeks non-weight bearing. Take us through like your BFR protocol you do with them. How quickly would you start? Pressures? Do you do exercise, not exercise?
Start as
Do you
early as
stem,
possible.
et cetera?
So as soon as that post-op wound looking appropriate from a we all feel confident, comfortable from that standpoint. And the doc
Is
is
doc
open
to that?
Yeah. So as we get rehab launched in our center, him and I are going to be working through our standardized protocols for our cartilage-based procedures and how we're going to handle BFR across the whole rehab team. And so the initial part would be, hey, as soon as we all feel confident, comfortable with starting the intervention, and a great place to start is that, Nascimento risk stratification tool. Here we go. Follow this. I tell so many clinicians and students, just if you print this, put it on your wall, laminate it, easy tool to run through. But once we get going, start initially with passive cell swelling, right? And maybe just have them do some quad sets, make sure they can tolerate it. I like to start people at lower limb occlusion pressures because we can always do more later. The last thing I want is not really an adverse event, but a vasovagal response, right? Or maybe they get uncomfortable. I have had that in the past early in my career where I'm like, all right, lower extremity, 80%, here we go. And it's like, oh boy, here we go. Nope, not yet. And then you have to reintroduce that therapeutic alliance. So less is more to start, but usually, start, hey, 40%, does that feel okay? Is this tolerable? Great. Next week we're going to go 60, or next session 2 days from now. Great. Now we're working on off from a contract relax. Hey, now we're going to throw E-stim on with that on the second time as well. Excellent. We're, run a NMES or Russian E-stim, whatever we prefer. From there, we're going to move into our open chain activities and the range of motion we have available to us, right, for as much as we can do, whether we try to get 20 minutes of tourniquet time, right? Anytime I put that tourniquet on you, I want to build up to 20 minutes, right? Initially, let's try to get 10, right? And then from there, add 5 minutes to eventually get to 20 by our third or fourth session. Why did I choose 20?
Why'd you choose 20?
Because everything I've read in the literature is like, hey, going a little further. There's like all the little points of like running the risk of an adverse event, but also from terms of a 20 standpoint, I know I can get 4 exercises in. I know I can get 4 exercises in from a 30, 15, 15, 15. And from an exercise dosage standpoint, I want to hypertrophy that tissue. So I know I need to get 10 to 15 working sets per week per muscle group, right? Within like 1 to 3 reps of failure if they like know what they're doing.
And the new ACSM guidelines.
Dude, it's great. Hypertrophy is a hell of a drug, and if you just do it, it's great. The muscle just grows. It's wonderful. But I think problem is people don't train hard enough to get to that point. So BFR early on in the rehab process with quad sets, 90-45 leg extensions, single leg raises, you start initiating with the person. This is what training to volitional fatigue is like, right? And this is where I need you to get to anytime we do anything so we can make the most use of our time with any activity we're doing. So I can probably get 4 exercises done within the 20-minute time block from a 30, 15, 15, 15 standpoint. I know that's 4 activities, 4 times 3, that's 12 sets we've accrued, right? So fantastic. We've done our 12 sets. That's within our 10 to 15 range. I know at the very least, at a minimum, we're going to grow today,
Perfect explanation. You didn't just say, I just chose 20. That was good evidence background. If we could teach any PTs something today, is understand the amount of sets needed for that hypertrophy
I
response.
literally, when I teach now, I say, if you don't remember anything from today, remember this: to put muscle on.
Lunch is not provided.
Lunch is not provided. Yeah,
That's what I
but
start.
put muscle on. It's about weekly volume. You have to get 10 plus sets per week is what ACSM guidelines said, I believe, when they came out. But it's also, the thing about that is it makes what you're doing, like at the end of the day, when that person leaves the clinic, you can say, hey, they did enough today.
Yes.
And I can prove to you that they did enough.
With the volitional
Or
fatigue component.
with the fatigue.
I mean, even though that's a little...
Or you can say, hey, they didn't do enough, but I know where I have to get them so that they are doing enough. And just the ability, our jobs are hard enough, Like, how long do you have to freaking bend a knee to get range of motion out of it? Like, how hard do you have to push? How many times do you have to push? How many times a week? How many times a day? We have no clue about one of the most basic things that we do in the clinic every freaking day. But when it comes to exercise and putting on muscle, like, we can actually just do the math, and it's not hard. It's not really complicated. I love it from that perspective.
Yeah. All right, man. So
sorry,
we've got your progression.
So now we've hit the 8-week mark. Say we're doing some weight bearing. Let's say we're weight bearing is tolerated, hopefully, right? We still have to worry about the joint, right? What can the joint tolerate? You know what I'm saying? So that's why BFR continues to be a helpful tool. And also, on top of that, we're also from the BFR, yes, we're hypertrophying the tissue and all that wonderful stuff, but all of these biomarkers or byproducts of exercise and then additional anabolic hormones are flooding down to this target tissue, right? And thankfully, the vascular system is not discriminative, right? Like the geniculate artery is going to come through the knee, right? And it's going to say, oh, like the femoral artery is going to bring blood to the quad, and then it's going to go down to the geniculate artery, right? The geniculate artery is going to feed the condyle surfaces. Wonderful. Excellent. So by dosing the quad, we've now inadvertently brought all this additional blood flow to this healing cartilage structure that is inherently not the most vascular, right? And so we're forcing it and dosing it with the body's natural anabolic response to grow, right? So that's part of one thing that we could probably talk about later with one of the studies we're looking at. We're working with the University of Kentucky, in one of the studies we're doing with it's a 2-year follow-up, right? Where we're also looking at joint surfaces and things like that to see how BFR or non-BFR is stimulating that component. So you have to be worried about what the joint can tolerate, right? And so again, BFR is going to help you make better use of your time, right? Rather than just someone laying down doing leg raises or anything, right? You can say, hey, this joint really can't tolerate much because it hasn't weight bared in a while. And also leading up to the cartilage procedure, they probably weren't the most weight bearing person, right? And they probably are still dealing with a number of components of inhibition. So continue to rinse and repeat, right? The same component, but then just change your exercise selection, right? Maybe it is some...
Yeah. Do you try to go more multi-joint once you weight bear, or are you still sticking with, accessory? Let's just lung our quad.
No, I like to integrate at least some weight bearing activities, right? I think a leg press is a phenomenal tool, right? As long as it's being done correctly, and you can stagger the stance, be single leg, all those wonderful components with it to just find a way to bias, loading the quad a little bit more, just play with the foot position on the leg press in and of itself, but then long our quads to the full range of motion. Another closed chain option, whether it be a step up or step down, right? But making sure they're working and whether the relative pain-free range of motion, and also being mindful of like the kinematics of that activity you're asking them to do. So it's really important to understand when you're and now moving into closed chain activities, where was the lesion kissing, right? Where was it articulating prior to the surgery, right? So then you can be more directed with your intervention. So let's say maybe it's the last 0 to 45 degrees of knee extension in the closed chain. Fantastic. You can still do closed chain activities. Just be mindful of how you're applying that. I think that's where we go wrong a lot of times in the rehab world. When we start to do a lot of the weight bearing stuff after these cartilage procedures, we do too much too soon. And we say, well, the available range is fine. Well, why'd it hurt in that range? Because that range has not, you have to think it's still an infant, like that cartilage is still infantile relative to the rest of the joint surface. So just from them walking around from a normal gait, right, initial heel strike, moving through the swing phase of 0 to 45 degrees, right, that's going to be enough for what that cartilage can handle walking around through the day. So you don't need to load that any further, right? Or if you do feel like you need to load it further, in comes walking under BFR conditions. So there's a number of different ways we can kind of finagle that. And also, like we were talking, don't forget about hamstring strength, calf strength, proximal hip, core stability, right? Because again, this athlete should never have left the weight room after their surgery. We should be concurrently training the upper extremities and all the other components, because exercise is a hell of a drug, right? If I train a heavy upper body, even though I'm doing a lower body rehab, that heavy upper body stimulus is going to downregulate myostatin, because it's a central adaptation to my whole body continuing to grow. So the more we can keep them training and keep them involved, we're going to be all set in the long run.
Do you have criteria then? We get this asked a lot. When do you stop BFR? And we know you got a cool way where you're looking at, a high mod down to low mod, which you take it probably further than most people typically do, which is good. But what's your criteria to start transitioning? Okay, I'm going to go more mod to heavier load and start peeling BFR back.
As soon as I get to the point where maybe I'm around an 80% limb symmetry index, if it's a knee pathology, I want at least 2.5 newton meters per kg. I know 3 is the criteria typically to run, but I know around 2.5 newton meters per kg, I can start to progress some heavier loading, because I know that quad's going to be able to be protective, right, of the joint surface. And maybe we have now progressing some moderate, more heavier loading with that individual, and moderate meaning 60 to 80%. Right? Low being under 60%, high being over 80% of what their estimated 1 rep max is, or maybe their reps in reserve or RER, right? So those would be some options available to them there. But even in my long-term post-op cases that I've had in the past at Rhode Island, like I was still using it when they were back playing. And they had passed all return to play criteria. They're doing everything just fine. He's getting carries. He's doing fantastic. He's out there playing linebacker. Everything's great. But I'm still making sure I'm dosing him with hypertrophic stimulus every week, because we know like an ACL injury or something like that is a neuromuscular injury, right? There's always going to be that cortical inhibition to say, hey, let's downregulate this a little bit. Hey, I know I can't train you too hard in the weight room because you got to play football, but I have to make sure I'm preserving physiologic cross-sectional area around this joint, because that's going to be the expression of strength and power. Because if we don't preserve cross-sectional area, we're going to then run into some, maybe some less than optimal movement patterns, right? We're going to limit our movement variability, and maybe we then end up with some form of alternative injury. So the way I looked at it was, hey, this is another tool that helps us, whether we're healthy or unhealthy, preserve cross-sectional area.
Thanks for taking us through that. It's good stuff, man. So let's get into C-Spar and what the facility is.
Yeah, so we are a multidisciplinary space. So right now we're just doing performance training for athletes of all levels, research, and then we also have a bunch of high fidelity testing equipment, whether it be VO2 max testing, force plate testing, motion capture analysis, you name it. We have a full fleet of technology and a beautiful weight room and things of that nature. We'll be launching physical therapy hopefully later this summer, and our build out within the space. And then also we'll be hoping to see some physician services later on as well, but more of our non-op stuff, because we won't have any imaging on site.
Tied in with the Patriots? Oh, you're out there in their area.
We're in the same, literally we're at Patriot Place with the Patriots, right? Our Mass General Brigham is the providers for the New England Patriots. So Dr. Martin is the physician for them. Mm-hmm.
BFR studies, what are you guys looking at?
Oh, yeah. So one of them we have right now is our brain study. So 1 minute here.
Yeah,
brain. So it's with the crew over in Kentucky. And so it's acronyms. I'm always bad at remembering them. So blood flow restriction training after patellar instability trial. Brains.
Okay. Oh, that's why it's brain. Okay. Kind of like our moon trial. And that's with Chris and Brian?
Yes. Okay. And so we're working hand in hand with them. So we have 2 different groups. One group is getting BFR and one group is getting sham BFR. Okay. And so I'm the interventionist on the study. So, and so I'm blinded to see how they progress over time in the study. And so it's 8 weeks, non-operative patellar instability. And so one person's going to get sham, one person's going to get real BFR, and then we work through them at the time 3 days a week over the course of 8 weeks, 8 to 9 weeks.
Your sham, how do you work?
The sham, so we're using a Katsu unit, the new Katsu unit, and then the way I've plugged it in and turn it on, it doesn't go over 20 millimeters of mercury. So as long as it's staying under 20 millimeters of mercury, but the thing's on, right?
Smart. That's good.
And And
So real no BFR, all they're getting is a little bit of pressure.
the same amount of pressure they would get from like a compression short, you know.
Okay, very cool. Oh, so it's hydro. Compression short BFR. Okay.
But the other group,
that's about a sham, because I know you told that to me earlier, and I was impressed that you did that. Because we've done it, and it's like 20 mils of mercury with the Delphi, and they're like, this isn't on, right?
Yeah, and that came from the Kentucky squad. I was talking to them, I was like, how are we doing this with the sham? And I was talking with Lauren Erickson down there, and she's like, oh, we have this old Katsu unit that actually doesn't go over 20. And I was like, okay, cool. So she sent one to us. She's like, this one doesn't go over 20 because it's broken. I was like, all right. And then it broke, and I was like, oh, we still need to do a sham. And so we ordered a new Katsu unit, and the way I interfaced it up, I was like, I can make this so it doesn't go over 20, and play with the plug a little bit, and then it works.
Okay.
It works great. But then we use the Delphi unit for the
actual intervention. Is Gary Dredge there? Is he part of that?
To my knowledge, no. He might at Kentucky. He may be.
Okay. He was working on his PhD there. He's one of my old interns, but he was part of a patellar tendinopathy trial in DOD with BFR a long time ago. So anyways, your Delphi intervention, 60, 70, 80% LOP, y'all ranging it? Okay,
60% LOP, 20 minutes of exercise, 20 minutes of tourniquet time, 4 exercises, 30, 15, 15, 15. The exercises are controlled throughout the whole, the BFRT exercises are controlled, being single leg press, single leg extension, a step up variation progressing into step down, and then Kaiser hack squat variation.
And your outcomes?
Outcome measures are going to be looking at strength measurements. So taking like handheld dynamometer strength, not handheld dynamometer, it's on a HUMAC, right? Okay. So biodexing them, 3D motion capture, gait analysis, looking at gait asymmetries between either groups. We also have a urine sample and blood draw, and then follow-up MRIs at visit 2, which is 2 weeks in, which is 4 weeks in, and then another follow-up MRI at 1 year, and then 2 years.
Wow. So it's funded, I guess.
Yes. So this is a DoD funded study. Yep.
Okay. Good. What's the urine sample? Just to see if they're pregnant?
Oh no. I think it's looking at. I gotta confirm what I should. I've been so locked in on just making sure I'm right with all the
measure. He's like, I can measure muscle protein synthesis in urine now. Huh. That's no big deal. I was just wondering. That's the only reason I've ever had to do urine samples and studies. Okay. Badass, man. And long-term follow-up. This should be good. What's your N?
Our N within the center right now is 3, and then we're multi-center with Kentucky, so I can't confirm how many they have, but we just really started building this out early in January, later into January.
So chronic patellar instability.
First time patellar dislocator, first time on that knee. So they could have dislocated the other one, but it's first time non-operative patellar dislocation.
Whoa. So you count.
I thought my phone was silenced. Sorry.
It
was silenced, actually.
Your Tinder account going on.
Yeah, exactly.
And no DOD sites, man, because we had a lot of patellar dislocations with some of our newbies. So just Kentucky, you guys, no DOD involved.
I think that's why they're using us, is to see if we can help fill, because our inclusion criteria is around like 16 to 30 years old. So trying to find the young, healthy population to best figure out ways to manage this. I think my only feedback on it so far is, it's 3 times a week, 1 hour of one-on-one physical therapy, right? And so even if you're getting the sham or you're not getting the sham, I think, you're going to make some improvements, because that's not really the standard of care in most in-network models, is getting 3 hours of physical therapy, a week. But I think, we'll see.
We'll see.
I'm blinded to the results.
Yeah, hopefully it moves the needle. I'm glad you're blinded. Very cool. What else you guys looking at?
We're doing some other studies that are non-BFR related with return to play testing. One with like MPFL reconstruction return to play testing battery. Another one with a long-term NEOA follow-up for people status post ACL, looking at 12-month, 24-month follow-ups. We have some other studies going on internally with MGB, and things of that nature. But the big ones we're looking to go after and continue to move forward is some additional BFR-based stuff. And we really are positive that and confident that once we get rehab services going out of our center, it's going to be a lot easier to enroll
Yes, for sure.
additional subjects. It'll be almost like shooting fish in a barrel, right? Because our docs do so much heavy sports medicine stuff within our Foxborough location that having everything under one roof is going to be really beneficial for that.
The cartilage piece, man. Just that you have such a big
Mhm.
cartilage doc up there. We have really no data on that, and man, that's the best. That's how I got in the NFL originally with Clowney with his cartilage problem, and I mean nothing like 8 weeks non-weight bearing to watch that modifiable muscle go the wrong direction. So I'm hoping, and so I know you and I talked about it. We already had kind of a multi-center cartilage group put together years ago that I did, and so we're hoping you guys can help us maybe rekindle that trial.
And that's certainly something we'd love to do. Christian and I were talking when we were over at Isokinetic. We're like, there's, great conference, tons of, literature being presented, and him and I were just riffing. We're like, man, there's really a great need for long-term follow-ups and looking at like the whole process with the implementation of BFR in these cartilage procedures, because they're super costly. Not just on like, we think the pro sport model, like it can be a career ender, right? Because a team just doesn't have the patience to wait 16 months for someone to come back. There's another kid coming out of college. They'll just rinse and repeat. You know what I'm saying? But also, if you think about the non-pro athlete, the recreational athlete, the high school athlete, right? The adult individual, right? This is very challenging for them to do a rehab for. And people say, oh, it's compliance. It's like, no, be an adult with kids and be non-weight bearing for 8 weeks. Good luck. You know what I'm saying?
Yeah.
Take 6 months out of work. It's going to be super challenging. So again, back to the thing we talked about in the very beginning of time, right? Time is our most valuable resource. So if we have an intervention here at blood flow restriction training that we know is tried and true proven to make better use of our time in the early postoperative states and load compromised individuals, this should be the standard of practice in cartilage procedures, is the utility of this across the board. There should be no excuses. It's like if your clinic sees people with status post cartilage procedure and you're not using this, you're failing the human.
What else are you able to do? Yeah, man, I know. Our hang up was, how do we look at the cartilage again? We can measure muscle pretty easily and some function and proms, but what would you say, because we were talking about like second looks, could you go back in, scope it, kind of see what's going on at the cartilage level? But do you think granularity with an MRI, you could see significant changes for a study, or would you just get a bunch of fibrocartilage? Or is there
I
any
don't know.
other thing out there I'm missing?
I don't know. I'm trying to think of like alternative ways that are non-invasive, because anytime you stick a scope in there or anything like that, you run the risk of,
I know it's a problem.
any form of adverse event. And plus the patient might not want to do that. Like what's the person going to want to do, right?
Yeah, it was a non-starter, but it's just like if you
but
had a perfect world.
if I had a perfect world, I would just go simple as just like maybe just looking at like inflammatory markers. If you just, I know we talk about not sticking something in a perfect world that is invasive but not as invasive as a scope, is just pull some synovial fluid and see how much biomarkers you have. Pair that along with imaging, and then an additional component. Always follow that up with a subjective outcome.
Yeah.
Right. How the person's perceiving they're progressing over time. Right. And then I also, and then you're just making a full blown study of it, and then have a strength measure, because you get someone who perceives they're wonderful, and they're like, I don't have any pain, and then their synovial fluids, a car that's had 10,000 miles on it without an oil change, and their imaging is a disaster, and they're asymptomatic.
Yeah.
Right. But maybe their biodex is like 3.5 newton meters per kg. Maybe they're just a monster. And it's like, all right, well, strength is protective, or maybe the activities the person's participating in, the lesion never kisses, so it's just, it kind of goes back and forth there,
Yeah. Well, yeah, like I said, strength and function is going to win at the end of the day, but we always get that question: what does it do to the cartilage? Or like, oh my God, hypoxia, the ACL is not going to repair, and Seth Sherman and the guys at Stanford are actually looking at a study, kind of using some special MRI techniques to show that the ACL is just fine, and we haven't seen that problem at all. So, well, first we got to get the study rolling, man. So, you guys, I'm going to lean on C-Spar to kick some ass between you and Doc. Maybe see if we can get a cartilage
between
study.
Dr. Latterman and Dr. Cale Jacobs, our director of outcomes research, we're looking everywhere we can to find a way to kind of get something like this off the ground, because it would be really beneficial, whether it be early supplemental aerobic exercise in patient status post this procedure with BFRT, whether it be, the whole, continuum of care, whether it be something as maybe a low entry point or another, because, think about Wolf's Law, like, thanks for introducing us to Abe over at Usarium,
Yeah. That's good.
maybe it's finding a pathway down bone stress injuries first before you then go into the cartilage component. But
Yeah. Very cool, man. Well, Mark, you're on the big things. You're still a young pup. Graduated 2019. I'm gonna conquer the world, baby. Pandemic.
Yeah.
Telehealth.
Yeah, that was weird, man. It was weird. It was like practicing for like 7 weeks or 7 months, and then was like, all right, telehealth this, and I was like, what? But
Yeah.
It's hard to do BFR.
And then we did that for like
telehealth.
2. No, it's good. No, did that. I mean,
You
did that
got
for
weightlifting
2.
straps in your house?
Yeah. Hey, go ahead and no.
Go 7.
7.
Go to 7. Yeah, does it feel tight? Good.
Yeah.
Look at your toes. Are they purple? Excellent.
Well, cool, man. Well, I think we're going to be talking quite a bit here in the future. And congrats on isokinetic and getting to hang out with the Grecians. Is that what you call them? The Greeks?
The Greeks. I think they're Greek.
I don't know. And everything is C-Spar, man. You got a big future ahead of you, and I can't wait to collaborate more. So thanks for coming on, brother.
Thanks for having me, guys. I really appreciate it.
All right, man. Take care. Thanks for tuning in to the Owens Recovery Science Podcast. Before we go, a quick reminder that the information discussed on this show is for educational purposes only and is not intended as medical advice. Always consult with your healthcare provider before making any changes to your treatment or training regimen. For show notes and additional resources, be sure to check out owensrecoveryscience.com. And don't forget to like the show and subscribe for more evidence-based insights. Until next time, earn your deflate.